Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi, this is Mike Sullivan at Valor Medical Services, and I'm one of the instructors here. And in this program, we'll be discussing immunological emergencies, also known as allergic reactions. Now, before we get too far in, let's talk about some of the basic core objectives for this class. We'll be going over the physiology related to allergies and anaphylaxis. We'll differentiate between mild, local, and more severe reactions, such as anaphylaxis. And we'll also touch a lot on the different medications used by pre-hospital providers in treating anaphylaxis. Now, these can include Benadryl, epinephrine, and Solumedrol. Each one of them is separate and distinct and attacks the reaction in a different direction or from a different perspective, and therefore we want to learn as much as we can about all of them so that way we can choose the best tool for the job when we're dealing with a patient who's experiencing some sort of reaction. Now, before we get too far in, let's go into allergens. A lot of common allergens out there these days we hear about, whether it be tree nuts or peanuts. Patients who are allergic to shellfish or shrimp, things like that. Dairy products can be a very common trigger for a lot of people. In addition, we have patients who are allergic to different medications, such as antibiotics, some pain meds or opiates, and some patients being allergic to aspirin. And again, we'll talk about what an actual allergic reaction is. We'll get a little further into that. Another common set of allergens is our bites and stings, whether it be wasps, bees, yellow jackets, ants, fire ants, spiders. Any of these can definitely produce an allergic reaction in a patient. And lastly, we'll talk about some of the plants out there, whether it be poison ivy, oak, or sumac. Some grasses patients will be allergic to, as well as some patients have very severe allergic reactions to different types of mold. Now, there's two different types of reactions we'll get into. First is an allergic reaction. Now, an allergic reaction is the immune system having an overactive response to some chemical it's been sensitized to, which is an allergen. This results in the release of a histamine and localized reaction. There can be swelling, redness, hives, itching, and sometimes you may see a more systemic presentation such as nausea, vomiting, diarrhea, and in many cases it's important to note that subsequent exposures may lead to more severe reactions, meaning a patient who has been stung by bees before and hasn't been very allergic now gets stung this time and is much more allergic than he or she was before. This is due to becoming sensitized to that specific allergen due to repeated exposures. Now, the other type of reaction we'll talk about is an anaphylactic reaction. Now, an anaphylactic reaction is much more significant than just a plain allergic reaction. When we talk about an anaphylactic reaction, we're talking about multiple body systems being affected, not just localized swelling at the site. This can well become a life-threatening systemic reaction with a mass histamine release through the body. It may lead to vasodilation and increased capillary permeability. This would lead to drop of blood pressure. We wouldn't actually be losing any blood or fluid. However, the much larger container due to vasodilation would cause blood pressure to fall precipitously. This, of course, again, shock, hypoperfusion, poor end-organ perfusion, may lead to respiratory distress due to bronchoconstriction and mucus production. It can also lead to soft tissue swelling of the upper airway as well as airway obstruction. All of that would be much more significant and life-threatening as it presents airway, breathing, and circulation problems as opposed to just straight allergic reaction. Now, our generic approach to any type of reaction, first off, we need to eliminate the allergen if at all possible. It's very important that if it's a sting or something along those lines, if there's a stinger still embedded in the patient, we do not use tweezers or pinch the top of the stinger to remove it. You want to actually use a rough edge, such as the side of a driver's license or a credit card or your paramedic ID, anything like that that you can use to scrape the stinger away without pinching the venom sac. The reason we want to avoid pinching the venom sac, if the patient's already been stung, that's bad enough. We don't want to risk squeezing the venom sac and injecting any more venom into the patient. Then we need to evaluate the ABCs. We'll assess the airway, breathing, and circulation, and this is going to also help us evaluate how bad the reaction is. We'll administer oxygen. We want to titrate it to above 94% SpO2. Establish an IV line for either fluids or meds, and if we're having trouble establishing an IV line due to hypoperfusion or shock, you may wish to consider an IO, especially at this point, because if the patient is already showing signs of shock and hypoperfusion, we will definitely need to be able to give meds. We want to start off by considering a bolus for hypotension. This bolus can be 1 to 2 liters fluid in an adult, or 10 to 15 mLs per kg in a pediatric patient. We should consider getting an EKG monitor in place and monitoring lead 2 continuously just to evaluate what's going on with the patient's heart. Once we've done this, a standard O2 IV monitor approach, the next step is to classify or stratify the reaction to determine exactly how bad it is, because that's going to be the key to our treatment, and that's going to determine how aggressive we need to get treating the patient. Now, when I talk about classifying or stratification of the response, we're going to put it into one of 3 groups: mild, moderate, or severe. Now, the mild group, it's a localized or large local reaction. It may have localized swelling, itching, hives. It's more of a nuisance. It's not causing any primary survey or airway breathing problems, no circulation problems, and blood pressure still maintaining. The typical cutoff between a mild and a moderate reaction is, do we have any airway breathing involvement? Once we have airway and breathing involvement, then we don't just have a mild reaction, we've got moderate. This can include wheezing, dyspnea, difficulty swallowing. Patient states their mouth, their tongue is swelling. They may be having trouble speaking. They feel like they can't get their mouth or their tongue to work properly due to the swelling. These would all be examples of an airway or breathing compromise starting up, and so therefore we triage this to be a moderate reaction. Lastly, we have severe reactions. Now, a severe reaction, the typical cutoff between moderate and severe is the patient hypotensive? Are there signs of shock or poor perfusion? This is getting a circulatory component into it. And so a lot of times we'll look at if it's moderate and then becomes severe, we'll have to treat it differently because of the hypotension and the circulatory component involved. Now let's look at how we're going to treat some of these different levels of reactions. Alrighty, so when treating an adult with a mild reaction, again, typically you're going to not require a great deal of treatment. However, we can do things to make the patient more comfortable, eliminate some of their itching. This will typically consist of diphenhydramine for managing some of the symptoms. Diphenhydramine is designed to block histamine receptors, decrease the effect that histamine's having, minimize the symptoms. You're primarily just, again, treating symptoms here. It should eliminate any additional histamine response, and that way won't allow the reaction to get any worse. However, it won't necessarily correct a lot of what's going on with the reaction. Now, the dosing for this is 25 to 50 milligrams IV or up to 50 milligrams IM. You may need to repeat it based on what your med control's orders are, how your agency works. You can also consider albuterol or beta agonist nebulized if you're having mild wheezing. 2.5 to 5 milligrams nebulized albuterol. That's very effective as it goes directly to the source of the wheezing in the upper airways, and that way we can open those up quickly with little or less side effects than you'd have with, say, epinephrine. Now, for a pediatric patient, the dosing is very similar. The diphenhydramine dosing is 1 milligram per kilogram. This can be done IV, IO, can be done IM, even PO. You may need to repeat it as with the adult dosing, and 2.5 milligrams albuterol via neb treatment. Again, trying to directly treat any wheezing that's starting to develop. Now, if it's already moved on past mild to a moderate reaction, and remember we classify it as moderate when there's some sort of airway or breathing issue, respiratory issue, wheezing, respiratory distress, we'd still go ahead with the diphenhydramine, the Benadryl, and the albuterol. However, in this case, it would also warrant getting on to Epi. Now, Epi can be found in many forms. In this case, we'll be using epinephrine 1 to 1,000, which is the more concentrated version, and it's designed to reverse many of the actions of the histamine cascade, including mostly the bronchoconstriction and vasodilation. Now, because this is the extremely concentrated version of the Epi, we'll go ahead and we'll give 0.3 milligrams, which is the same as 0.3 mLs, IM, and then we can go ahead with solumedrol, which is an steroidal anti-inflammatory used to treat respiratory distress, and the dosing for that is 125 milligrams IV or IO. Now, moving on to a pediatric dosing. Again, initial, we'd start with our mild level treatment for diphenhydramine and albuterol, but as we see, starting to have airway or breathing issues, then we'll get into the epinephrine, and again, trying to reverse the actions of the histamine cascade, and in this case, it would be 0.01 milligrams per kilogram IM, up to a max of 0.3. The Epi-pen Junior is 0.15 milligrams, again, just to sort of put that in perspective, how much we're giving. As well, we can still go with the solumedrol as a secondary. It's an anti-inflammatory. The dosing on this would be 2 milligrams per kilogram IV or IO to a max of 125 milligrams. Next up, severe treatment for an adult. Now, if you've got an adult who's having a severe reaction, one of the big hallmarks of the severe reaction is poor perfusion, signs of shock, many times peripheral vasodilation. So as a result of this, the body's not getting the IM medication. It won't deliver it as effectively as it would if we had gone via the IV route. So In order to go the IV route, we have to use epinephrine 1 to 10,000 instead of 1 to 1,000. And this again is designed to reverse the actions of the histamine. The dosing for Epi 1 to 10,000 is 0.1 to 0.3 milligrams, slow IV push. And this would be 1 to 3 mLs of liquid out of a 10 cc syringe that you'd have for your typical cardiac arrest prefills. When we look at Solumedrol, again, it can definitely play a part in the IV or IO administration. Again, it won't be as quick, but it will be more of a long-term solution, and hopefully not only is an anti-inflammatory, but treat some of the respiratory distress. The pediatric dosing for these, again, epinephrine will go with the 1 to 10,000, and that would be slow IV push, 0.01 milligrams per kilogram slow IV, up to a max of 0.3 milligrams. Now, if you're dealing with an extremely small patient, you may actually mix the epinephrine down even further to 1 to 100,000. The advantages of this will give you more controlled dosing. Remember, if we're trying to give 0.01 milligrams per kilogram, this would be giving 0.1 milliliter. Trying to give 0.1 milliliter out of a standard syringe can be somewhat difficult. However, if we make it out into 1 to 10,000, we'd actually be giving 1 milliliter, which is much easier for us to measure and deal with from that standpoint. Solumedrol dosing on this is 2 milligrams per kilogram, IV or IO. Again, never over 125 milligrams. So now that we've talked about what our dosing is and what preparations we'll be using, let's look into these drugs a little bit further. Now, epinephrine. It is the cornerstone of treatment for moderate to severe reactions. It really isn't warranted for a lot of the more mild reactions. It's kind of an overkill situation for that. However, in a reaction with any type of airway or breathing compromise or any type of signs of shock, we definitely get into epinephrine. This will reverse many of the life threats associated with the anaphylaxis, and epinephrine comes in a variety of preparations and forms. Side effects common to all of it is going to increase pulse, it's definitely going to increase blood pressure, and myocardial oxygen demand. So we need to always make sure that we're doing, if we're going to be giving epinephrine, make sure the patient is getting properly oxygenated. Again, we talked about O2 sat, keep it above at least 94%. We want to use caution if the patient's over 45 or if they've got a cardiac history, and especially if you have both. And anytime we're administering epinephrine via the IV route, it is always a very slow, gentle IV push for all these patients. Now, some of the common versions of epinephrine that's out, this is 1 milligram of epinephrine in 1 ml of fluid. It's the most concentrated. It can be supplied via vials or ampules. Sometimes you'll find it in the Epi auto-injectors as the same type of epinephrine, the same highly concentrated epinephrine, trying to get a good dose of medicine without a whole bunch of excess carrier fluid. Now, while this is great and the lack of fluid makes it ideal for the IM use, it's definitely not ideal for IV use, and we never want to use this style of Epi-IV. What we would use in the IV setting is epinephrine 1 to 10,000. It's the same 1 milligram of epinephrine, except now it's watered down 10 to 1 in 10 mLs of fluid instead of just 1. This is what's available in our standard pre-filled syringes for when we work, say, cardiac arrest or things like that. Or you can actually make it by taking the 1 ml of Epi 1 to 1,000, pull it up into a 10 cc syringe, and dilute it with saline. Another option for Epi, like I mentioned, with extremely small pediatric patients when we're trying to have very fine controlled dosing, is Epi 1 to 100,000. Now in this case, we have, instead of 1 milligram per ml or 0.1 milligram, we have 0.01 milligrams per ml. Now this can be used for pediatric patients, not only give slower, more gentle administration, It can also allow more control. It's not commonly prepackaged this way. Typically, this is something we'll make in the field very quickly. You take an Epi 1 to 10 prefill, and what you'll do is you'll expel 9 mLs of fluid from your Epi prefill and refill it with 9 mLs of saline. Once you've expelled it down and you've gotten 9 mLs out, at that point we still have 0.1 milligram in the syringe, but when we fill the rest of it with saline, it is now 0.1 milligram in 10 ml, or Epi 1 to 100,000. Now, you'll also find Epi auto-injectors. There's several different brands on the market, and they all work basically the same. The common one everyone talks about, I hear a lot of people say Epi-pen. I think that's just a generic term for any type of Epi auto-injector, but it is actually one of the brands out there. The yellow adult Epi-pen has 0.3 milligrams of epinephrine in it. The Epi-pen Junior has 0.15 milligrams of Epi 1 to 1,000 in it. Both of these patients may well have. They're utilized about the same way. We'll get into that in a minute. Now let's talk about some of the other brands. Another common one that came out recently is AviQ. Now the AviQ is a little bit different in that it's got 3 different doses. The red, or the adult, is for anyone over 66 pounds, and it's 0.3 milligrams, much like the Epi-pen adult is. The blue is 0.15 milligrams and is ideal for patients weighing between 33 and 66 pounds. The white, with the purple labeling on it there, that one is 0.1 milligram, and that would be ideal for a patient 16 pounds and up, or 16 and a half pounds and up. Now, again, most times the patients will either have their own, so we won't have to choose it, but we need to also have in the back of our mind that just because we only have a pediatric Epi-pen, 2 pediatric Epi-pens or 2 Epi-pen Juniors equal 1 adult Epi-pen, much like in this setting, 2 of the blue AviQs equal 1 red, 3 of the white and purple ones equal 1 red. So if we need to possibly improvise a little bit, we know what the dosing is. Just because it says junior doesn't mean it won't work on an adult. May just mean we need more than one of them. Now, to use any of these auto-injectors, the first thing we need to do is go ahead and remove the blue safety cap or plug from the end of them. Once we do that, we want to press it firmly into the lateral thigh and hold in place for at least 10 seconds. This is to allow the drug to get in. Once we do that, discard it appropriately. As we pull away, it's going to self-sheath the needle, and ideally it should cover the needle and protect it from any needle sticks or anything like that. In closing, patients are seeing more and more patients with allergic to different things, thus allergic reactions are being more and more common. These patients, some may have no idea that they're at risk. They may have been stung before and not have had a problem, and this may be totally new to them. Or someone may be very allergy aware, and they may carry an auto-injector. However, we never know if they're going to be familiar with their auto-injector. Again, they may be panicking, they may be confused, or they may have a family member with them, especially in the case of a child. Whoever the caregiver is at that time may not be familiar with their auto-injector, and therefore we need to have a little bit of knowledge and background about not only these tools, how they work, and how they're deployed, and that way we can assist with these. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.